All of these contribute to increase the prevalence of hypertension in Nigeria. Despite taking medications, most people still have their blood pressure not controlled. And when blood pressure is not controlled, it can lead to significant problems like cardiovascular diseases, renal failure, and increase in mortality. Globally, 27% of patients with hypertension do not have their blood pressure controlled among high-income countries, whereas in the low-income countries, the values are much lower. 10% of patients with hypertension have their blood pressure controlled. The remaining 90%, despite taking medication, their blood pressure is still not controlled. So we decided to conduct a study to assess the determinants of blood pressure control among the hypertensive patients we were seeing in our facility. So the study was a descriptive cross-sectional study and was conducted in the general and medical outpatient clinic of ISTH. So we used both the family medicine clinics and the medical clinic, as the cardiovascular clinic, the renal disease clinic, and all the outpatient clinics where hypertensive patients were being seen. And we used systematic sampling to recruit 502 consenting adults who were diagnosed with hypertension and have been hypertensive for at least 1 year. This study was conducted in 2021 between January and March. We used a semi-structured questionnaire to collect data. The questionnaire was pre-tested and pre-validated. The blood pressure was checked using the Omron Digital Classic IntelliSense, and we did 3 recordings and took the average of the last 2. Blood pressure greater than or equal to 140/90 was categorized as not controlled according to WHO, while those with blood pressure less than 140/90 were categorized as having controlled blood pressure. We also checked the waist circumference using a non-stretchable tape, and we checked the hip circumference and determined the waist-hip ratio. For the purpose of the study, waist-hip ratio less than 1 for men and 0.9 for women were classified as normal, while those greater than or equal to 1 for men and 0.9 for women were categorized as obese. So the data was analyzed and ethical approval was obtained for the study from the Ethics Committee of Iro Specialist Teaching Hospital. We obtained written informed consent from the participants prior to commencement of the study. What were the results? At the end of the study, 55% of our study participants were female. The mean age of respondents was 52.98 with a standard deviation of 12.82. More than half of them had secondary education. 44.6% of them earned below the minimum national wage of 30,000 naira per month because they were mostly traders and farmers. Most respondents, 66.1% were married and over 70% were Christians because the study was conducted in Edo State where we have most of our patients Christians. Majority of our respondents had poor blood pressure control, 64.8. So the control rate was less than 40%. 19.7% of them had fair control and only 15.5% had optimal blood pressure control, which is in line with the global statistics. So this is a chart indicating the blood pressure control among the respondents. Now the study found that highest level of education, monthly household income, employment status, marital status, and religion were significantly associated with blood pressure control. In other words, those with a higher level of education had better control, and those who had more money had better blood pressure control. Those who had better jobs or who were married had better blood pressure control. The study also found a significant association between blood pressure control and level of physical activity. So those who were more physically active had better control compared to those who were less active. Those who did not smoke cigarette had better control compared to those who smoked. Those who consumed less salt had better blood pressure control. And duration of hypertension also was found to be significantly associated with blood pressure control. And then the waist-hip ratio, which was a measure of obesity, was again associated. So those who were not obese had better blood pressure control compared to those who were obese. And then blood pressure control, when we further subjected the result to linear and multiple logistic regression, it was shown that blood pressure control was more likely to be controlled if the respondent had a household monthly income that was 50,000 or more. Therefore, emphasizing the need to increase the national minimum wage for workers. Marriage was also significantly shown to be associated with blood pressure control. Those who were married had stronger family support and therefore had a higher chances of getting their blood pressure controlled. Being physically active also was shown to have a greater association with improved blood pressure control, and not being obese was also associated. What was the limitation of our study? Our study was hospital-based, and we know most patients don't come to the hospital. They buy their drugs in patent medicine store or traditional healers. Some don't even know their blood pressure control. So all of those people who didn't come to the hospital were not captured by our study. And then the response was based on self-report. So it was what the people told us that we used to determine. What if they lied? So recall bias was a limitation in this study. And then we did not look at the role of medication adherence in blood pressure control. We just looked at whether the blood pressure was controlled or not. We looked at the socio-demographic characteristics, and then we looked at obesity. What about if they were taking their drugs and that is what made the blood pressure control? So this is another limitation. We did not assess medication adherence. And then other comorbidities like diabetes mellitus, dyslipidemia, and renal status could have affected control. These were co-founders that the study did not know. So in conclusion, our study showed that the respondent study had a low and unsatisfactory blood pressure control level, and this finding in a tertiary setting may imply that lower levels of healthcare may have lower control rates. So the problem could actually be worse than is depicted. And then numerous socio-demographic and lifestyle variables were shown to be associated with blood pressure regulation. The recommendation from this study, therefore, is that in patients with hypertension, lifestyle adjustment of risk factors like obesity, as well as non-drug therapy approaches, should necessarily, therefore, be emphasized and intensified in addition to adherence to drug treatment. Thank you very much.